Good morning, everybody. Is that okay there? Can everyone hear? Right. Well, thank you for that introduction, Dr. Moran, and thank you to Drs. Kinney, Dr. Sharma, and Dr. Moran again for the invitation to speak today. I'm just trying to work out how to sort all this out. Oh, wrong way. That's the end of my talk. Right. Here we go. Right. I'm going to talk about MINOCA, scad, and the index of microvascular resistance. 4 topics that I could actually talk about for over an hour, but I won't, don't worry. We'll keep to time. These are my disclosures. And let's start with MINOCA. MINOCA has been talked about for the last 80 years or so. And in fact, I was only actually given the tag of MINOCA in 2013. MINOCA is diagnosed as myocardial infarction with non-obstructive coronary arteries, and the definition actually involves using the classification of the fourth universal definition of MI criteria, so a rise or fall of cardiac troponin associated with cardiac sounding chest pain, ECG changes, and some imaging modality showing ischemia. In addition to no evidence of any significant coronary artery stenosis more than 50% in any major epicardial vessel, and also the exclusion of other alternate diagnoses that can cause a similar presentation, such as sepsis, pulmonary embolism, and myocarditis. So what do we need to think about when we consider giving the diagnosis of MINOCA? Well, they're the non-coronary and extracardiac presentations which can mimic MINOCA, and in particular we need to think about myocarditis and Takotsubo cardiomyopathy, which have recently been removed from the MINOCA group of diagnoses. Other cardiomyopathies, cardiac trauma, sepsis, pulmonary embolism can all cause chest pain and troponin rises, but are not true MINOCA presentations. So the coronary presentations and the coronary vascular presentations are the ones we need to think about, and those are really what I'm going to concentrate on today. So in particular, plaque disruption, scad, coronary spasm, coronary thromboembolism, and coronary microvascular dysfunction. So how do we make the diagnosis? We use this quite eloquent diagnostic pathway, looking firstly at the clinical history, the ECG, echocardiography and cardiac biomarkers, and follow this with coronary angiography, which demonstrates no obstructive lesions. And obviously an LV angiogram at that point can also help with the diagnosis of excluding the diagnosis of Takotsubo. Today we're really going to talk about the coronary causes, but the non-coronary causes are often very precisely defined by CMR performed in a timely fashion, so it's cardiac MRI, and also provocative tests not performed so soon after the initial presentation. So the coronary causes we're going to talk about are investigated by using physiology testing, in particular FFR, CFR, and IMR, and also the intravascular imaging we've heard about today, intravascular ultrasound and OCT. But really, the diagnostic pathways are essential to provide a definitive diagnosis, which is crucial to provide the optimal treatment for our patients. So what is the utility of intravascular imaging in MINOCA presentations? This very eloquent meta-analysis performed by Policia looked at over 8,500 patients and actually broke the investigations down into different groups. So looking at coronary imaging, we find that about 29% of patients presenting with MINOCA present with plaque erosion or disruption, and about 16% of patients present with spontaneous coronary artery dissection. And then if we look at the yield of IVUS in MINOCA as an investigation, in this study performed actually in New York by Harmony Reynolds in 2011, before the actual MINOCA tag was devised, about 50 patients were reviewed, and IVUS helped with making the diagnosis in about 70% of that group by defining plaque disruption, plaque rupture, and plaque ulceration. When we look at OCT in more recent studies, it's even more helpful. In this group, looking at 40 patients with MINOCA presentations, OCT was helpful in defining plaque rupture, plaque erosion, scad, calcific nodules, and most importantly, thrombus, which seems to be the real defining difference between OCT and IVUS in MINOCA presentations, in that OCT is a much better modality for determining the presence of thrombus. So when we put intravascular ultrasound and OCT against each other on a head-to-head, what are the advantages and disadvantages? IVUS is an ultrasound-based modality which has a lot of years behind it, so we've been using it for 30 years. It allows deeper penetration, allowing a better assessment of the plaque, the lipid content in particular, and looks very nicely at vessel remodeling. But the disadvantages are that thrombus detection is challenging, the plaque morphology is less well visualized on the superficial level, and the findings can be difficult to interpret when not by an expert. But when we look at OCT, which is an infrared light modality, the advantages are that the resolution is so much better, it's user-friendly, and plaque rupture is very well recognized and characterized. And the disadvantages really are to that group of patients that have impaired kidney function, in that we have to use contrast flushes, and that is necessary to clear the vessel lumen. So IVUS, it seems to be the modality of choice in SCAD presentations, and I'll talk about that in a second, but OCT seems to come out the clear favourite when it comes to MINOCA presentations, as it seems to be the superior tool for imaging coronary plaque pathology. So let's have a look at some OCT images. MINOCA is often caused by thrombus either with plaque erosion or plaque rupture, and in image C you can see at sort of between 6 and 9 o'clock the fibrous cap has thinned, and there's an area of thrombus adherent to the fibrous cap there. And in image D you can see plaque rupture, which is obviously a perfect portal to capture further clot and cause a STEMI type presentation. And plaque disruption is responsible for 35 to 40% of MINOCA presentations. When we look at thrombus on the OCT, you can see that it is much better visualized, and thrombus acutely looks quite irregular, and over the course of a week, if you image it repeatedly, you'll see that it smooths out. But thrombus can obscure the underlying vessel wall because of high signal attenuation. And as we said, IVUS detection of thrombus is more challenging, but maybe high-definition IVUS will lead the way forward for us in the future. So now talking about spontaneous coronary artery dissection, and again, another condition that affects women much more than men, especially middle-aged women, with fewer traditional cardiovascular risk factors, and it accounts for up to 35% of all ACS cases seen in women under 50. So the thing to remember about SCAD is that SCAD can be a cause of MINOCA presentations, but it doesn't automatically become a MINOCA presentation, because sometimes it causes more than 50% stenosis in a coronary angiogram. And of course, we know that there are sex-related risk factors in this group of patients. So what do we do with SCAD? So we know that SCAD has been classified according to 3 different types, and type 2 is broken down to A and B, depending on how the distal vessel reorganizes. And so type 1 and type 2 are usually quite visible on angiography. And I think really what we have to remember is that sometimes you can take a safe situation to a very unsafe situation by just manipulating an investigative catheter or an intravascular catheter, and is it really necessary? So if you've made the diagnosis of SCAD with angiography alone in type 1 and type 2, then you probably don't need to do much more. But in type 3, where there's more ambiguity and there's a bit of overlap between this, could this be atheroma, could this be a type 3 SCAD, then imaging is definitely worth considering. And in this group in particular, IVUS is safer and has greater penetration. And you can see on the bottom there, the 2 images. I think OCT may not always be better in, say, the CTO field, but it actually does produce much prettier images, doesn't it? Right, so now I'm going to finish off with the utility of coronary functional testing in MINOCA presentations. And again, from that very elegant meta-analysis by Policia and colleagues, when they looked at coronary functional testing, they found that about 28% of MINOCA presentations were related to spasm, either spontaneous or provoked, and up to 32% of MINOCA presentations could be related to microvascular dysfunction. So looking at INOCA, INOCA is another umbrella term, similar to MINOCA, but obviously missing the M, because there's no myocardial infarction involved, it's just ischemia, and it encompasses a number of different presentations, so non-cardiac chest pain, vasospastic angina, and microvascular angina, and also a mixed picture of both. So what do FFR, CFR and IMR measure? Well, you already know everything there is to know about FFR from my colleague, Dr. Alami, but fractional flow reserve shows flow limitation and lesion level ischemia, and looks at the epicardial stenoses. Coronary flow reserve is an assessment of vasodilator capacity of the coronary vascular bed during hyperemia. And the index of microvascular resistance, which is what we're interested in, is a guide wire-based measure of coronary microvascular function. So how does IMR work? Well, basically, it doesn't take seconds, really. It takes probably as long as this presentation. So passing the pressure wire to the distal vessel, we flush the catheter and then perform 3 saline boluses at ambient room temperature at rest, and then again 3 saline boluses of 3 mils each with maximal hyperemia. And we measured the transit time. The transit time is the time taken for the temperature drop across the proximal to distal sensor on the pressure wire. So really, it's a very simple procedure that can be performed at the end of your diagnostic coronary angiogram. And what are the normal ranges? So the IMR is normal if it's less than 25, and if it's above 30, it confirms coronary microvascular dysfunction, along with the CFR less than 2. So when should we use IMR assessments? Well, we need to be thinking a bit more about how we assess our MINOCA patients. A diagnostic angiogram is not the beginning, not the end of the diagnostic process, it's the beginning. And we need to use microvascular dysfunction assessments for both stable angina in OCA patients and in patients with recent or acute MI presentations, for instance, MINOCA patients. It doesn't significantly add to procedure complexity or time. And we've got to remember that the CORE-MICA trial showed us that there's a huge benefit of diagnosis. Knowing what is wrong with you makes the patient's stress levels reduce and makes their quality of life improve quite significantly. So I think it should be part of a routine diagnostic pathway for MINOCA. And really, this is now the time for considerate and thoughtful cardiology. So what future work do we need? We need to have multi-center clinical trials investigating both the prognostic impact of diagnostic and therapeutic strategies in MINOCA patients. And the MINOCA BAT is one of those trials looking at beta blockers and ACE inhibitors and angiotensin receptor blockers in 3,500 patients with MINOCA, and it's due to complete in 2025. But we need also to think about a standardized global protocol for coronary physiology assessments. There seems to be a lot of variability. Should we stop caffeine? Should we stop beta blockers? Should we change any other therapies prior to the assessments? And obviously, if these patients are acutely admitted in hospital, it can be quite difficult if they're being treated for a STEMI presentation and they're on a number of these drugs already. So our take-home messages today are that MINOCA is not a benign diagnosis. It's a diagnosis that's associated with a significant mortality and morbidity. And as I said earlier, a normal angiogram after a MINOCA presentation is not the end of the road, it's the beginning of that diagnostic pathway. OCT predominantly and IVUS have a great utility in MINOCA, and in particular IVUS for type 3 SCAD. And we also need to think about the index of microvascular resistance along with the CFR as being a useful tool in CMD assessments. And it should become part of our routine workup for MINOCA. But really to remember that better diagnostics allow more targeted and appropriate therapies for our patients. Thank you for your attention.